Hey everybody, Ethan here. Today I'm going to talk about long QT syndrome and Torsades de Pointes. And I apologize in advance, I probably mispronounced that horribly and will continue to. But this topic actually got me thinking down a characteristically windy train of thought. And let's just go down it briefly. If you know me, you know I have a long-term, deep love for random idioms and expressions. Just saying them. I just love pulling them out. And the reason why is, well, for one, in speech and debate, I learn a ton of them. But if we want to go deeper, I think it's I just have this natural penchant for being dramatic. Let's say I'm at a dinner party and someone says something about how Sally here at the table is the worst at something. Let's say someone says Sally's the worst runner here. And let's say I disagree. Let's say I think Sally is being underestimated. If I was a normal person, I could just say, hey, don't underestimate Sally's running ability. Or I could say, be careful. Hey, with Sally, underdogs still bite. And I could pat myself on the back for being a little interesting and clever. In reality, it's dumb, but it's different. And hey, I like being a little different sometimes. Maybe that's also why I don't get invited to many different parties, but that's irrelevant. That's an aside. But back on topic, learning about long QT and torsades, goodness gracious, got me thinking about one of those idioms that I learned in debate and love to say, that being out of the frying pan and into the fire. In short, getting out of a bad situation and getting yourself into a worse one, or just another bad one. We can quibble about the semantics here. But I thought of this expression making this video because metaphorically, the frying pan, in terms of torsades and long QT, is an arrhythmia or any number of health conditions, but yes, especially arrhythmias. And doctors can try to get out of the frying pan of these conditions, of these arrhythmias, by treating them with antiarrhythmic drugs or other drugs that happen to lengthen the QT interval. But the risk, as the idiom states, is using those drugs to get out of the frying pan of those conditions and ending up getting oneself in the fire as a result. And the fire in this metaphor is what you see here, torsades, a heart rhythm abnormality, which I'll get into briefly, but you don't have to be a clinical cardiologist to look at this EKG of torsades, compare it to the normal sinus rhythm here below, and say, yeah, that one above, that definitely looks like a problem. So that in mind, my plan today is simple. Simple, maybe lengthy, but I apologize in advance. There's three things. I want to talk about what long QT syndrome is. I want to talk about what are torsades de pointes. I want to talk about how long QT can lead to torsades de pointes. So that's the plan. Let's get started. What is long QT syndrome? In a nutshell, it's a lengthened ventricular action potential. But before we just hit us right, I want to provide some context. When we talk about long QT, we're talking about the QT interval, which is this interval here outlined in blue on this EKG. This relates to the cardiac action potential seen here on the right. And the QT interval, as you see here, sort of like from here all the way over to here, corresponds to sort of the entirety of the ventricular action potential, which is essentially both depolarization, seen here, phase 0, depolarization, and then repolarization all the way out to here. As the name suggests, a long QT syndrome means you have an extended QT interval or an extended ventricular action potential. Because depolarization is lightning fast, as you can see here in phase 0, the real lengthening in long QT syndrome really tends to happen in repolarization. It begins as a sort of tug-of-war in between calcium and potassium. Right? You have potassium efflux and calcium influx, and at first in this phase 2, it sort of balances out, but especially in phase 3, potassium really takes over and brings us back down to Earth and repolarizes us. So you can imagine, if you want to lengthen this QT interval, lengthen this sort of period by which this action potential is occurring, you could use a potassium channel blocker like amiodarone, seen here, a class 3 drug, because to stop potassium efflux, by stopping potassium efflux, you keep our potential elevated, right? You don't allow this to be brought down back to Earth and repolarize. And by keeping that potential elevated, you allow for the lengthening of this action potential and therefore the QT interval. And if you have a sharp eye, you might remember that amiodarone was on our list right here on the right of drugs that can get us out of the frying pan and into the fire. They can get us into a dangerous situation with long QT and torsades. But sort of going back to here, I want to just make a note. It's not just potassium channels that could be a potential culprit in regards to long QT. You could imagine opening more calcium channels, right? Calcium channels is what helps counterbalance the potassium efflux in phase 2. By opening more of those calcium channels, you can bring in more calcium and resist the potassium efflux that could thereby prolong this action potential. And the same goes for sodium. Basically, anything that causes an excess of intracellular positive charge will slow down repolarization, prolong the action potential, and prolong the QT interval as a result, causing long QT. But generally, potassium is the culprit, and that's really the basic pathophysiology of long QT. I focus almost exclusively on drugs here, but it's important to realize there's other causes of long QT syndrome. Long QT can be inherited, it can be congenital, right? If you inherit a malfunction in genes that code for the specific ion channels we're talking about, whether it be potassium channels or other, you can lead to excessive intracellular positive charge in the same way that blocking channels with drugs like amiodarone can cause long QT. But long QT can also be acquired. And a key thing to think about is just general electrolyte disturbances, right? We think so much about the channels, but the ions only move through the channels due to gradients, which of course are affected by the serum concentrations of these ions. Hypokalemia, hypocalcemia, a lot of these hypos can all cause long QT syndrome. And lastly, as I've mentioned, drug-induced long QT. I've talked about amiodarone and we talked about antiarrhythmic drugs, but it's important to remember that drugs that don't expressly treat heart rhythms can also block potassium channels, including antibiotics like fluoroquinolones and some antipsychotics, and that can cause long QT syndrome as well. A last thing I want to leave you with when it comes to drug-induced long QT syndrome. I focus so much on potassium because the fact of the matter is potassium is the primary culprit in causing long QT. But an important thing to remember, especially with the antiarrhythmics, is that the simple class 1, class 2, class 3 system doesn't encapsulate all the effects that these drugs have. Because I'm telling you potassium is the general culprit, that means, oh, okay, it's only class 3 that's a problem, because class 3 is those potassium channel blockers. However, class 1 antiarrhythmics, such as quinidine, are notorious for prolonged QT interval. But if you go off that class 1 designation, right, seen here, class 1 sodium channel blocker, you might wonder, what? Ethan said potassium the culprit. Why is class 1 drugs at risk here for prolonged the QT interval if they are sodium channel blockers? And Ethan told me potassium's a culprit. Well, you have to remember that these distinctions between class 1, class 2, class 3 are not as cleanly cut as we might want to believe. Sodium channel blockers like quinidine, especially these class 1A drugs, don't only block sodium channels. Drugs like quinidine also block potassium channels, which explain their ability to prolong the QT interval. So just as a side note, don't forget, these classes of drugs can do more than just their headline might tell you they can. So with that out of the way, let's move on and talk now about Torsades de Pointes. All right. In short, it's a polymorphic ventricular tachycardia. But sort of just as we discussed before, it really is referring to a bad looking heart rhythm, this one seen here below. But how specifically is it bad is the question. If we refer to an actual medical expert or textbook, unlike myself, it says that Torsades de Pointes is a type of polymorphic ventricular tachycardia, characterized on electrocardiogram by oscillatory changes in the amplitude of the QRS complexes around the isoelectric line. That is a mouthful. Let's break it down. And I want to start with that ventricular point. Why does it matter this is a ventricular rhythm? And what does that mean? Remember that in a normal heart, the initial pacemaker impulse originates in the sinoatrial node, then travels down here throughout the atria, then gets to the AV node where it goes on, right, to the bundle of His, bundle branches, ventricles, and so on and so forth. The key is that the SA node should trigger the whole process. SA node right here, see number 1 here. That should trigger the whole process, and the atria should be polarized first before the ventricles, seen in this upright P wave here on this ECG, or EKG. Same thing. This leads to ventricular depolarization, of course, that big QRS complex. But in Torsades, it's a ventricular rhythm, specifically a ventricular tachycardia, right? In Torsades, the SA node is not driving the ship, something in the ventricle is driving the ship and initiating these depolarizations. That's really evident when you compare these rhythms side by side. In this sinus rhythm, you have this P wave leading to QRS, but in this Torsades, you don't really see a P wave leading to QRS. You're just seeing these large, broad QRS complexes here. These are ventricular depolarizations, and you're not seeing any P waves preceding them. This pace is being driven by the ventricles, and that pace, importantly, is very fast. It's a tachycardia. Just as a review, the cutoffs for heart rate abnormalities, bradycardia under 60 beats per minute, normal is between 60 and 100, and tachycardia is over 100 beats per minute. So Torsades is a fast heart rhythm, a tachycardia, driven by originating in the ventricles. But more specifically, it's a polymorphic one. What does that mean? Well, here are 2 ventricular tachycardias, and you're familiar with the bottom one. This is the same picture I keep showing you of Torsades. Above is a ventricular tachycardia, but specifically a monomorphic one. There is a singular shape, right, or morphology of this broad QRS complex that doesn't vary from beat to beat, right? This one looks more or less the same as this one. Unlike Torsades, which clearly has, beat to beat, this one looks pretty dang different than that one, right? And it just looks sort of all over the place. And that's sort of the key when you think about that polymorphic word when it comes to that description of torsades. Speaking of all over the place, seeing this ECG over and over again actually reminded me of something. Actually reminded me of how it looks eerily similar to my handwriting, which also exhibits beat to beat, or in this case, letter to letter variation. I don't even know if you call it these letters, but this is, yes, an actual screenshot from my notes, right? But that aside, there's one more attribute we need to talk about when it comes to torsades. That's where the name itself comes from. Apart from being a polymorphic ventricular tachycardia, the name Torsades de Pointes, and again, probably butchered the pronunciation, apologies, it means twisting of peaks in French. And that refers to how the amplitude of the QRS complex consistently and gradually changes or twists around the isoelectric line, right? That amplitude is not the same. And that's a characteristic feature between that and other polymorphic ventricular tachycardias. Compare the torsades below with the catecholaminergic polymorphic VT seen above. Again, these are high-level rhythms, all right? Apologies. But it's looking at this one above, you see beat-to-beat variation. Like this beat looks different than the next beat, but the key is that this rhythm above here is bidirectional. The axis seems to shift. You see, one axis seen here, and then one axis way down here. The axis is switching sort of 180 degrees with each beat. But unlike torsades, you don't see the shifting, twisting changes in QRS amplitude. You see, look at this amplitude here of this torsades beat versus the amplitude of this torsades beat. That's that shifting, twisting of amplitude that really characterizes the torsades, specifically that specific rhythm you're talking about. So in short, that is torsades, which isn't great on its own for the heart and body because you can imagine this kind of heart rhythm of extremely fast ventricular beats can lead to low cardiac output. Why is low cardiac output a feature of torsades? Well, just think, right? The ventricles can't fill enough to actually push out blood because remember, without coordinated atrial depolarization before the ventricular depolarization, it's hard to actually get blood in the ventricles. Because after all, the goal of atrial contraction is to get blood in those ventricles, and those atria are not contracting in coordination with the ventricular contractions in torsades. But further, because we're contracting so quickly, because this is a tachycardia, the sheer rate the ventricles are moving means there isn't enough time to fill said ventricles before they contract and push out the little blood they have in them. The risk here is the low cardiac output caused by torsades can translate into hypotension, which obviously leads to end organ dysfunction. If your organs aren't getting enough blood, they're not going to work well. But when we're thinking about the heart, right, it's concerning as well because of something called coronary hypoperfusion. Remember that from basic cardiac anatomy that the heart's own perfusion via the coronary arteries seen here all originate from the root of the aorta seen here. And, getting blood flow into that root of the aorta to go through the coronary arteries depends on function atrial and ventricular contraction of the heart. It depends on a decent cardiac output in order to put blood into the coronaries. So in a setting of ventricular tachycardia, such as torsades, causing low cardiac output, the heart itself can be hypoperfused. That can lead to a degeneration from ventricular tachycardia to ventricular fibrillation, which is even more dangerous. Ventricular fibrillation, seen below, is an extremely dangerous heart rhythm that can lead to death in minutes. It is a type of ventricular tachycardia, technically, where the heart is beating very fast. You can tell this rhythm is not slow, but critically, it is uncoordinated. The heart is basically flailing around. And that means that cardiac output, already low in normal VT, is going to get shot down even further. And that's really, really bad because even lower cardiac output means even worse hypoperfusion of the heart and the body as a whole. And that's how you really can, unfortunately, pass away. So that's torsades in a nutshell and sort of the risk that torsades generating into VFib. To be clear, it doesn't always lead to VFib. It can spontaneously resolve, but this is the risk when you have torsades. So we've covered long QT, we've covered torsades. The final question remaining is why are the two related? How can long QT lead to torsades? And in a nutshell, it's due to heterogeneous extension of the vulnerable part of the cardiac refractory period. But what does that mean? Let's get into it. Let's go back to first some more EKGs. What we see here, of course, is a normal sinus rhythm. And it's clear as day when you compare this rhythm here on the right. The one on the right has an extended QT interval. The QT is from like here to here. That interval is long compared to this interval from here to here, right? And that T wave being way out there means that the ventricular repolarization is delayed, meaning that the ventricular action potential is lengthening. And yes, while that's not ideal, this rhythm here you see in long QT certainly isn't anything like what we see at the bottom, which is the dangerous torsades rhythm. And to understand how the top right can become the bottom rhythm, we have to understand something about the cardiac refractory period. So you remember this ventricular action potential diagram from earlier, right? And it's important to remember that during this phase 3 part of repolarization, this potassium efflux, predominating and the cell is repolarizing, the myocyte is also in what is known as the relative refractory period, or just the sort of the end of the refractory period, where even though we are trying to repolarize, technically the sodium channels that gave us that phase 0 depolarization can reopen again. In long QT syndrome, what does happen? Well, we prolong the QT interval, meaning we prolong repolarization, meaning we prolong this critical period during phase 3 where the heart is vulnerable to an off-rhythm stimulation. And in the context of long QT syndrome, if you get a stimulation leading to a new depolarization known as an ectopic beat, seen here, you can get a genuine new depolarization even during what should have been repolarization. Because remember, this is part of like that relative refractory period where the heart is vulnerable to a new depolarization because those phase 0 sodium channels can reopen. And when you get this sort of new depolarization, this is actually known as an R on T phenomenon, which I think is very aptly named. Remember, the R wave on electrocardiogram seen here is correlated with ventricular depolarization. We know that. The T wave seen here is correlated with phase 3 repolarization seen here. So when we have a ventricular depolarization, when we add on that ectopic beat, right, to phase 3, we're introducing a ventricular depolarization, an R wave, onto a T wave during the time of a T wave in phase 3. So therefore, we get ourselves an R on T phenomenon. And that R on T phenomenon can happen more often during long QT because there's a longer, more vulnerable T wave for the R wave to act on, right? Because we're stretching out the report. Let's say we've put in this patient amiodarone, so these potassium channels are blocked. This phase 3, this slope is going to be shallower. It's going to be longer, giving more time for that relative refractory period to occur, more time for a random ectopic beat to happen, a stimulation to stimulate this myocyte and give us this additional action potential you see in this weird line that I've superimposed on this Google Slides. So that R wave, that early ventricular depolarization seen here with this line, is, yes, it can happen because this QT thing is enlarged, and yes, it is too early, because naturally the next action or depolarization should have occurred after phase 3, then phase 4, and then you get a phase 0 like off screen. So yes, now we have two beats that are sort of very fast in succession. But torsades, as we know, isn't two fast beats. It's a ton of fast beats. It's a tachycardic rhythm. How do we get there is the question. Let's think now about what long QT does, right? It extends repolarization. We talked about it. It extends the QT interval, extending the ventricular action potential. I've said that like ad nauseum today. But what's important to understand about the extension is that the extension is not uniform. There is a dispersion, as it's called, of repolarization. Some myocytes may be in this critical vulnerable period of phase 3, while others won't at a certain given time when you have a patient in long QT syndrome. And why does that dispersion matter? Something called reentry. This is a broader schematic of reentry, but the basic idea of reentry is that depolarization doesn't always have to follow the normal order of operations, right? So this green here, you see normal conduction. You see, okay, AV node, blah, 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 bundle branches, and it goes off to the sides. That's the normal order of how, depolarization of heart should happen. However, in red, you see if how tissue is diseased in some way or has some heterogeneity, and whether it's susceptible for depolarization, the wave of depolarization can actually loop back on itself, seen here in red. This looping and the self-perpetuation of said looping is dependent on the loop having varying timing of repolarization. But what I mean by that is at this critical point here, if this red arrow tissue right here is not repolarized or in a critical vulnerable period where it can get depolarized, then at this point, this red pathway isn't going to depolarize. It's just going to not be able to be depolarized, and we're going to continue down this green path. However, if this red tissue at this key junction here is actually susceptible to being depolarized, then this could happen. And if this next tissue is then also repolarized and vulnerable, then it can get depolarized and we can get this. And by the time we get back here, then maybe this initial green tissue here is also repolarized or vulnerable, and then we can get it depolarized down here, and we get ourselves this sort of loop. As I mentioned earlier, in long QT, the repolarization of this tissue of myocytes is dispersed. It's heterogeneous. So why that matters is that when we get this ectopic beat on one individual myocyte, this random R on T phenomenon, this stimulation during this lengthened key vulnerable interval of the refractory period, the fact that long QT syndrome means that we have this difference between different myocytes of when they're being repolarized and vulnerable means the myocytes around this individual key one with the R on T phenomenon, the myocytes around that one are on different stages of repolarization. and that's a plus. It means that maybe one myocyte surrounding this key myocyte might be in the vulnerable part of the refractory period, meaning that after this one's get depolarized, maybe that can cause the next one to get depolarized. And then now, once that second vulnerable myocyte gets depolarized early, a nearby myocyte to that one finally now can enter the vulnerable part of the refractory period, and it can depolarize early. And fraction of a second later, after that early depolarization happens, maybe a new myocyte next to that one can get vulnerable and get depolarized, and so on and so forth. And eventually, the first myocyte, the first one with that initial R&D phenomenon that started all, will enter the vulnerable part of the refractory period, and some other myocyte down the road can stimulate it, and we get ourselves this circulating reentry phenomenon, and we get ourselves torsades. So that was sort of all over the place. Let's sort of put that all together here with the sort of roadmap of how torsades happens. Remember, long QT lengthens the repolarization phase of the action potential, lengthening the vulnerable portion of that cardiac refractory period in that phase 3 when potassium efflux happens. The R on T phenomenon occurs because this vulnerable period is longer. It can just be random. This random beat can just happen, and that means that it can happen more often on this vulnerable period, causing an early ventricular depolarization, that little added hump, right, before it should have happened later. The lengthening of repolarization across the heart tissue is heterogeneous, meaning that nearby myocytes to that initial one that got early depolarization, the nearby myocytes reach vulnerable portions of the refractory period at slightly different times. And this heterogeneity, these differences, allow for early depolarization to propagate, because once one depolarizes, then finally now might be time for another one to be ready to be depolarized, and then after that one, another one, and so on and so forth. This is reentry, and this abnormal rhythm perpetuates itself and ultimately leads to torsades. So that's sort of the connection between long QT we talked about and torsades. So hopefully that made some sense, but let's just sort of review everything we talked about today and summarize. What did I talk about today? 1, long QT syndrome involves extension of the ventricular action potential, generally due to inhibition of potassium efflux. Torsades is a dangerous polymorphic ventricular tachycardia with twisting, right? There's some big and then some small amplitude waves of this ventricular tachycardia about that isoelectric line. And long QT lengthens the vulnerable portion of the cardiac refractory period, leading to a higher chance of these R on T phenomena. This lengthening is heterogeneous, allowing this rapid abnormal rhythm to perpetuate itself via reentry. I hope this makes some level of sense. Obviously, in some ways, a simplification. Actually, there is still some research being done on this because a lot of important details about this process are still being elucidated. But I hope this gives you at least a basic understanding of not just long QT and tachyarrhythmias and torsades, but just in general, how this sort of makes sense from an electrophysiological perspective. So yes, I hope this was at least somewhat helpful, maybe a little entertaining. I wish you all the best. Take care now. These are my works cited, of course, in reference. Have a good one. All right. Bye-bye.